Robert was 71 years old, retired postal worker from Columbus, Ohio, 32 years carrying mail through every season. His doctor put him on a water pill about a year earlier to manage his blood pressure. Robert took it every night before bed, exactly as he was told. One night around 2 a.m., he woke up needing the bathroom, swung his legs off the bed, stood up, and the room tilted. His vision went black. He reached for the wall and missed. Hit the bathroom tile. Hip fracture. Surgery the next morning. 6 weeks in rehab. 8 months before he could walk to his own mailbox again. Here is what haunts me about Robert's story. His medication was working. His numbers were excellent. What failed him was something no one had discussed. The timing of that pill. I am Dr. Michael Carter, and if you or someone you love takes blood pressure medication, this video could change how you think about every single pill you swallow. Because the danger I see most often in my patients over 60 is not the wrong medication. It is the right medication taken at the wrong time. Your blood pressure is not one number. It is not the reading your doctor takes during a 10-minute visit. Your blood pressure is a 24-hour landscape. It peaks in the early morning when cortisol rises. It dips during deep sleep. It spikes when you stand and shifts with every meal. I call this the 24-hour pressure map, and here is why it matters. Your doctor prescribes medication based on one reading at one moment. But that pill lives in your body all day, interacting with every peak and valley on your map. When timing is right, the medication works with your rhythm. When timing is wrong, it works against it. And after 60, the margin for error shrinks dramatically. Your blood vessels are stiffer, which means they cannot adjust to sudden pressure changes the way they used to. Your nervous system responds slower, so the signals that tell your heart to pump harder when you stand take longer to arrive. And your kidneys clear medication at a different pace, which means the drug stays in your system longer and hits harder at its peak. Today, I am walking you through 5 blood pressure medication timing mistakes, quietly putting seniors at risk. Number 1 involves a pill that can turn your bathroom into the most dangerous room in your house. Number 3 is something your doctor has almost certainly never tested you for. And number 5 involves a common breakfast item that can turn your medication toxic. Before we begin, type your age in the comments and tell me whether you take your blood pressure medication in the morning or at night. I want to see the split. Number 1, the diuretic bedtime mistake. Patricia was 69, retired librarian from Tucson, Arizona. Her doctor had prescribed a diuretic for blood pressure, taken every morning for 2 years without problems. Then, at a routine visit, he suggested switching to bedtime dosing, based on newer research about nighttime blood pressure benefits. Within 2 weeks, Patricia was up 3 to 4 times every night, exhausted. 3rd week, a 2 a.m. bathroom trip, she slipped on tile, fractured her hip. 8 weeks recovery, months of therapy. The research confirms this pattern. A meta-analysis in the Journal of Urology found that people who wake up twice or more per night have an 84% higher fall risk. 3 or more times, 115% higher risk. A 2023 review in European Geriatric Medicine flagged diuretics specifically as causing nocturia, orthostatic hypotension, and dehydration in elderly patients. A 2024 study from the University Hospitals Birmingham, following 299 adults over 65, found diuretic users at significantly elevated fracture risk. Here is the full cascade, and I want you to follow every step. Diuretic at bedtime. The medication increases urine production during the exact hours you are supposed to be in deep sleep. You wake up once, then again, then a 3rd time. Each time you stand, your blood pressure is already at its lowest, because that is what healthy sleep does. It drops your pressure. The diuretic has pushed it even lower. Now you are standing in a dark room. Your eyes have not adjusted. Your balance system is still half asleep. Your body cannot compensate fast enough. Dizziness, a misstep, a fall, a fracture, surgery, weeks of rehabilitation, and in too many cases, a permanent loss of the independence you have spent your entire life building. 1 timing decision, 7 consequences. None of them were necessary. What to do instead? Take diuretics in the morning or before 2 p.m. If your doctor suggested bedtime dosing, ask specifically about nocturia risk given your age. That single question could prevent what happened to Patricia. But her diuretic is not the only trap. The next mistake happens before most people eat breakfast. Number 2, the morning empty stomach drop. James was 73, former high school football coach from Nashville. He took amlodipine every morning with just water, no food. For months, he felt lightheaded when standing, a slight wobble, a dimness behind his eyes. He blamed it on age. One morning, he bent to tie his shoes, stood up, and blacked out for 3 seconds. Fell into the doorframe, bruised ribs, emergency room. The doctor told him it was orthostatic hypotension, blood pressure dropping too fast when he stood. The fix was not a new medication. It was eating something before taking the pill. On an empty stomach, medication absorbs faster and peaks harder. No food to slow the process. Think of it like pouring water straight into a funnel versus pouring it over a sponge first. Without food, the medication floods your bloodstream all at once. Your blood pressure drops sharply, you stand up, gravity pulls blood toward your legs, and your brain needs a rapid adjustment to maintain blood flow. After 60, your arterial walls are stiffer, and your baroreceptors, the tiny sensors that detect pressure changes, respond with less urgency than they did decades ago. The body simply cannot compensate fast enough. And the result is that brief, terrifying moment where the world disappears. A 2025 review found orthostatic hypotension affects 10 to 30% of elderly individuals, linked to falls, cognitive decline, and cardiovascular complications. A Lancet Regional Health Europe study in 2024 confirmed that hypertension and orthostatic hypotension frequently coexist in older adults. A separate longitudinal study found orthostatic hypotension, measured just 30 seconds after standing, was associated with significantly higher fall incidence over 12 months, with a prevalence above 23%. James needed a piece of toast, not a new prescription. His doctor adjusted the routine. Small breakfast first, pill 30 minutes later. Lightheadedness gone within a week. What to do instead? Never take blood pressure medication on an empty stomach unless specifically instructed. A few crackers, a banana, a handful of nuts. And if you feel dizzy in the mornings, sit on the edge of your bed for 30 seconds before standing. Let your body adjust. If you have ever felt dizzy standing up in the morning, type the word dizzy in the comments. I want to know how common this is. Number 3, the non-dipper blind spot. I am not going to share a patient story for this one. Instead, I want you to understand a concept that could permanently change how you think about your blood pressure. When you sleep, your blood pressure is supposed to drop 10 to 20%. This is called nocturnal dipping. It is when your heart rests, your vessels recover, your organs repair. People with this pattern are called dippers. But 25 to 35% of older adults are non-dippers. Their blood pressure stays elevated all night. While they sleep peacefully, their heart, kidneys, and blood vessels are under continuous strain. Non-dippers face significantly higher risk of stroke, heart failure, and kidney damage. Not from anything they did during the day, but from what their body failed to do at night. Now here is where the blind spot lives. The BedMed trial, published in JAMA in 2025, followed over 3,000 patients for 4.5 years and found no significant difference in cardiovascular outcomes between morning and nighttime dosing. Headlines everywhere said timing does not matter. But a separate study, the Oman trial in JAMA Network Open the same year, followed 720 patients and found bedtime dosing did improve nocturnal blood pressure and circadian rhythm in patients whose nighttime pressure was not dipping properly. Your doctor prescribes medication based on a single daytime reading. They almost never order 24-hour ambulatory blood pressure monitoring, the one test that reveals whether you are a dipper or non-dipper. If you are a non-dipper with all medication in the morning, your most dangerous hours go unprotected. If you are a dipper with medication moved to bedtime, you may be pushing already low nighttime pressure dangerously lower. Ask your doctor about 24-hour ambulatory monitoring. You wear a small cuff for 1 full day and night. It takes readings automatically while you go about your life and while you sleep. It maps your entire pressure landscape, every peak, every valley, every nighttime dip or lack of one. One test could rewrite your treatment plan entirely, and if your doctor has never mentioned it, that is not a failure on your part. It is a gap in how blood pressure is routinely managed in this country. Now you understand the landscape, but there is a timing mistake that has nothing to do with the clock and everything to do with how your medications interact inside your body. Number 4, the all-at-once crash. Evelyn was 76, retired school teacher from Portland, Oregon. She managed her blood pressure with 2 medications for years, both taken at 7 a.m. Then her doctor added a third, and her cardiologist started a cholesterol medication. 4 pills, same time, every morning. Within a week, Evelyn had episodes where her vision narrowed like a tunnel. She would grip the kitchen counter and wait for it to pass. Her daughter brought her back to the doctor. The answer was not a new diagnosis. 4 medications reaching peak concentration simultaneously were creating a synchronized blood pressure crash. After 65, the average person takes 5 or more daily medications. When multiple blood pressure drugs peak at the same hour, the combined drop exceeds what any single one intended. Each medication is designed to lower your pressure by a modest, safe amount. But when 3 or 4 of them all reach peak concentration within the same 60-minute window, those modest amounts stack. A younger body compensates by pumping harder and tightening blood vessels. But with stiffer arteries and slower reflexes, a 76-year-old cannot adjust fast enough. The result is a trough, a window of dangerously low pressure lasting 30 to 90 minutes, long enough for dizziness, confusion, or a blackout. And because it happens gradually and then resolves, many patients never connect these episodes to their medication timing. The European Geriatric Medicine Review flags combined antihypertensive use as a modifiable fall risk factor. The Stop-Fall Clinical Decision Tree, designed for elderly fall prevention, includes protocols for evaluating whether blood pressure medications should be restructured when patients experience falls. Evelyn's doctor staggered her medications, 1 in the morning, 1 in the evening, with the other 2 spread across the day so that no more than 2 reached peak concentration at the same time. The tunnel vision stopped within 10 days. She told her daughter it felt like someone had turned the lights back on. What to do instead? If you take 2 or more blood pressure medications, ask about staggering. Spreading doses across the day eliminates that dangerous synchronized trough. This is critical if you have ever felt unsteady in the hour after your morning pills. If you take more than 1 blood pressure medication, type the word stagger in the comments. That might be the most important word you learned today. Number 5, the breakfast time bomb. Howard was 68, semi-retired accountant from Scottsdale, Arizona. Health conscious, walked every morning, watched his sodium. For 20 years, he started each day with half a grapefruit. Then his doctor prescribed felodipine, a calcium channel blocker. Nobody mentioned grapefruit. Within days, severe headaches, swollen ankles, racing heartbeat. Emergency room. His blood pressure was dangerously low on what should have been a moderate dose. The culprit was breakfast. Grapefruit contains compounds called furanocoumarins that block an enzyme in your gut called CYP3A4. This enzyme is your body's gatekeeper. It is responsible for breaking down many medications before they enter your bloodstream, including several calcium channel blockers. When you eat grapefruit, that gatekeeper gets shut down. The medication passes through with no filter, no buffer, no control. Felodipine absorption can increase by up to 300% with grapefruit. That is not a minor interaction. That is a moderate dose behaving like a triple dose inside your body. And a single glass of grapefruit juice can suppress that enzyme for 24 to 72 hours. But grapefruit is not the only concern. ACE inhibitors and ARBs like lisinopril and losartan combined with high potassium foods, bananas, spinach, avocados, can push potassium into dangerous territory called hyperkalemia. Your heart depends on precise potassium balance to maintain its rhythm. Too much can cause irregular heartbeat or worse. And real licorice root, not the candy flavoring but the actual root found in some herbal teas and natural supplements, contains a compound called glycyrrhizin that causes sodium retention and directly counteracts blood pressure medication. You could be taking your pill perfectly and wondering why your numbers are not improving, never suspecting the tea you drink every afternoon is working against you. Howard's doctor switched him to a medication that does not interact with grapefruit. Symptoms resolved in a week. He still eats his morning grapefruit. What to do instead? Ask your pharmacist for a complete food-drug interaction list for your specific medications. Pharmacists are trained in these interactions and often catch things prescribers miss. On calcium channel blockers, avoid grapefruit entirely. On ACE inhibitors or ARBs, be mindful of potassium-heavy foods. Check every tea and supplement for licorice root. Those are the 5 timing mistakes. Now let me give you something you can take to your next appointment. I call this the timing check. 5 questions. 1. What is the best time of day to take this specific medication and why? Not the generic label answer. The answer for your age, your health, your routine. 2. Should I take this with food or on an empty stomach? As you saw with James, this can mean the difference between a normal morning and an emergency room visit. 3. Are there foods or drinks I need to avoid or time separately from this medication? Do not assume your doctor will mention this. Ask your pharmacist the same question. You may get a longer answer. 4. I take multiple medications. Should any be staggered rather than taken together? If your doctor has never considered it, Evelyn's story is your reason to ask. 5. Have I ever had a 24-hour ambulatory blood pressure test? If no, you do not know whether your medication is protecting you during your most vulnerable hours. These are not confrontational questions. These are not questions that undermine your doctor's expertise. These are smart patient questions, the kind that signal you are engaged, informed, and serious about your own health. Any good doctor will not just tolerate these questions. They will welcome them. Let me bring this back to Robert. 71. Retired postal worker. Strong heart. Good numbers on paper. His diuretic was doing exactly what it was supposed to do. His blood pressure was controlled. Every checkup confirmed it. But the timing of that pill turned his bathroom into the most dangerous room in his house. A 2 a.m. fall, a fractured hip, months of rehabilitation, a year before he felt like himself again. All of it preventable. If someone, anyone, had asked question number 1, if someone had said, Robert, let us move that pill to the morning, his story ends differently. He keeps walking to his mailbox, keeps tending his yard, keeps living the retirement he spent 32 years earning. The BedMed trial in JAMA 2025 concluded that for the general population, morning versus nighttime dosing does not dramatically change cardiovascular outcomes. That is an important finding, and I respect the science behind it. But the message has been misread by doctors and patients alike. It is not that timing does not matter. It is that there is no universal answer that applies to everyone the same way. The OMAN trial showed timing matters profoundly for non-dippers. The diuretic data shows it matters for fall risk. The food interaction research shows it matters for how much medication actually enters your blood. Timing is personal. It depends on your rhythm, your specific medications, your kidney function, your sleep pattern, and your daily routine. That conversation should not be a footnote scribbled on a prescription pad. It should be the conversation itself. The pill does not know what time it is, but your body does. After 60, your body keeps a very precise clock. Your blood vessels know when it is morning. Your kidneys know when you are sleeping. Your heart knows when you stand up at 2 a.m. in the dark. The question is not whether your medication works. It works. The question is whether it is working with your body or against it. That is not a question your doctor should answer alone. That is a question you deserve to be part of. A medication taken at the right time is medicine. The same medication taken at the wrong time is a risk. Remember that. If this video helped you see your blood pressure medication differently, subscribe to this channel. I make these videos because I believe you deserve to know what is happening inside your body, especially the details your doctor skips. Have you ever experienced a side effect that turned out to be a timing issue? Has your doctor changed when you take a medication and it made a difference? Tell me in the comments. Your experience might protect someone else watching right now. And one more thing before you go. You now know when to take your blood pressure medication. But do you know what that medication is quietly doing to your body every day? In my next video, I break down 6 silent side effects of the 3 most common blood pressure medications, amlodipine, losartan, and lisinopril, that your doctor dismissed as just aging. If you take any of those 3, that video is right here. I will see you there.